This is episode 28 of the Med Edit podcast, your ultimate resource for evidence-based medical education.
And the only podcast where two board-certified physicians interview specialists addressing topics that the listeners choose.
In this episode of the Med Edit podcast, we tackle another touchy subject, overactive bladder. This topic request came to us directly from a listener through our Instagram.
So, overactive bladder syndrome is a chronic medical condition which has a tremendous impact on the quality of life in both men and women, affecting performance of daily activities, social functions such as work, traveling, physical exercise, sleep, sexual health. This is an extremely important topic to shed light on, and we have an expert in urology joining us today in the studio.
Don't miss the second half of today's episode where we address a TikTok conversation about peeing in the shower.
I can't wait to hear how this relates to overactive bladder syndrome.
We are your hosts, Dr. Cari Sorrell
and Dr. Jessica Gray.
Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the Med Edit podcast.
Let's start with the basics. The definition of OAB, or overactive bladder, was updated in 2010 by the International Continence Society, and it is a condition with characteristic symptoms of urinary urgency, or feeling the need to urinate suddenly, usually accompanied by frequency and nocturia, which means going to the bathroom overnight, with or without urgency incontinence, which is wetting yourself or urinary leaking, in the absence, of course, of having urinary tract infection or other obvious pathology. It is suspected that at least 33 million Americans suffer from overactive bladder syndrome. And that's probably a low estimate, as many people don't often disclose these symptoms, and many patients fail to seek help altogether due to embarrassment. Nocturia, or getting up to use the restroom during the night, was found to be directly related to decreased sleep quality, decreased health-related quality of life, and depression in the elderly population. Although overactive bladder can affect children and young adults, this condition is most common in patients who are over 40 years old.
So today we have a guest who is a leader in her field and works directly with the Texas Tech University Health Sciences Center Urology Department, Kristen Sharma. Kristen Sharma is a certified family nurse practitioner with experience in the field of urology. She's an integral part of the TTU-HSC urology team and sees patients in her clinic at the University Medical Center. Her clinical interests include recurrent urinary tract infections, urinary incontinence, pelvic organ prolapse, and neurogenic bladder. She is often a speaker on this subject matter at medical conferences representing her department. She is passionate about education and helping her patients lead healthier lives. Welcome, Kristen, to the Med Edit podcast.
Thank you for having me. I'm very excited to talk about overactive bladder with y'all today.
Kristen, tell us why you are passionate about treating overactive bladder.
So as you mentioned, this is such an important quality of life issue. I have patients tell me stories about how they're afraid to go to family get-togethers. They don't want to go to church because they're afraid of having an accident in public. So again, it affects so many aspects of life. So socialization, intimacy, work, sleep, as you already mentioned. So unfortunately, many patients suffer for years before they even bring this up to their provider. So, that's what I love about it, is to be able to help these patients regain their life and not have to worry about the bathroom and where it is 24/7.
I think that's so important, right? It's your self-esteem. It's how you define yourself. If you all of a sudden start limiting where you're going, who you're seeing for something as simple as what your bathroom functioning, right? It's something we take for granted when it is feel like it's going well. But how does somebody know what is normal? Often patients will think, urinary frequency or urgency is just part of getting older or just part of being a woman, right?
So let's go back to basics for a minute. If we think about the bladder, it has two main jobs: to store urine and to empty urine. So overactive bladder is basically a problem with storage of urine. The bladder itself is mostly made up of muscle. And it's only supposed to squeeze when we tell it to squeeze. We have a control center in the brain called the pontine-micturition center that helps to control that we pee at an appropriate time, at a socially appropriate time. I tell patients that overactive bladder is kind of like the bladder is spasming and squeezing. So sometimes the brain knows that there's a bathroom around or here's running water and makes us feel like we have to go, leading to the feelings of urgency, frequency, and again, some patients do leak with overactive bladder as well.
So basically what's normal is when we're having the leakage or having these things, doesn't have to be normal is what you're saying, right? That we
Yes.
don't have to
So
just
sorry.
assume that is.
Yes. So sorry to answer your actual question. Normal is considered peeing up to 7 times a day and waking up to 1 time at night. So anything more than 1 time at night is considered abnormal.
Okay, that's really good to
While
actually have numbers to look at too, because a lot of people will sit there and they're like, "Well, I think that's normal." Same for Carrie when she talks about bowel movements for patients. That what is somebody's
yes.
normal? Okay, so you said, just for summarizing, 1 time at night getting up would still be considered normal, right?
Mhm.
Okay, and then up to 7 times in a day would be considered normal. But if we're going more frequently than that, or getting up multiple times in the night, that would be abnormal.
Correct. So even though overactive bladder is more common with aging, especially in my postmenopausal patients, it is not something that we just have to deal with. And it is not just part of being a woman. So with that being said, also have patients in their 20s with overactive bladder, as well as male patients. So I deal with mostly female patients, but males can also have overactive bladder. A lot of bladder symptoms in men are often attributed to the prostate, but they get overactive bladder too. And a lot of the treatments that we talk about today are applicable to them as well.
What causes overactive bladder?
So for most patients, overactive bladder is what we call idiopathic. So it just happens and we don't have a good reason for it. There can be other causes or other medical conditions that can contribute to a patient's symptoms. And that's what the office visit is for. We do a good history and a physical to see what else is going on, or is this just plain old overactive bladder? Other things that we try to identify as problems include constipation, glucosuria, so sugar in the urine. So if patients have uncontrolled diabetes, all that sugar in the urine is just irritating the bladder and making you have those symptoms. Some of the medications now that are being used for diabetes also make you pee out sugar, so that kind of contributes as well. And it's not that we necessarily stop those medications, but we kind of know that, hey, this is part of the process. Sleep apnea can play a role in nighttime urination as well. So
Oh, I didn't know
I
that
often
one.
have I have patients where, they'll say, hey, during the day, I'm fine, but it's at night, I'm waking up 3 or 4 times, and they might only be peeing 3 or 4 times during the day. So in those cases, I ask, hey, are you snoring? Do you wake up gasping for air? And if that's the case, then I want them to go back to their primary care provider and talk to them about sleep apnea. Uncontrolled sleep apnea can lead to a lot of problems, including nighttime urination, but also problems with the heart. And obviously, that's something that we don't want to miss. So when we control sleep apnea, symptoms get better. And again, part of the problem with sleep apnea is that we actually make more urine at nighttime. So, when we can control that process, that oftentimes gets better. In our postmenopausal women, especially, we talk about how the lack of estrogen within the bladder actually does increase symptoms. So what happens is when we lack estrogen in the bladder, when we're postmenopausal, the bladder just becomes more sensitive to stretch, so leading to those feelings of frequency and urgency. And we call this genitourinary syndrome of menopause. OAB can also be due to pelvic organ prolapse. So if the front vaginal wall is falling down, oftentimes it is dragging the bladder down with it. And so when we have that anatomic problem, if we fix the anatomic problem, oftentimes that helps with the symptoms. So there are options for that, which is why a pelvic exam is very important for all of our patients. Overactive bladder symptoms can also be a neurologic problem. So in our patients who have neurologic histories such as multiple sclerosis, they may present with many of these same symptoms, but we do have to have other considerations for these patients, such as their renal function. So there's a little bit more of a workup that we do for these patients. But in general, this is a clinical diagnosis. So again, once we talk to the patient and do an exam, then we come up with this diagnosis.
So a patient who comes to see the urologist or someone should expect to have a pelvic exam as well. Kind of sometimes I feel like it helps to prep somebody before they go in, that they may know that that's part of that exam to understand what may be going on and causing it, right?
Yes, that is definitely part of our National American Urological Association guidelines is to perform a pelvic exam on our female patients. Yes, ma'am.
Awesome. So the big question in everyone's mind, though, is how do we treat this problem? Because once you have it, whether you're 20 years old or, postmenopausal, male, female, whatever, you're definitely not comfortable. And you're like, I just do anything to get rid of it, to not be rushing to the bathroom or having that urinary leakage, any of those issues. What are our options?
Yeah, thankfully, we have many options to treat overactive bladder, and many of these options can be done in the primary care setting. It doesn't even necessarily require a specialist many times, which is fantastic, especially for our patients, here in West Texas, where they have lack of access to urology. So we often have to do a combination of strategies to control symptoms. So doing nothing is an option, however. Sometimes I'll have patients, maybe they're coming in for other reasons, and we're talking about their urinary leakage and their symptoms, and, it doesn't bother them. They're managing with pads and briefs, and that's okay. Some of the drawbacks with that is pads and briefs are very expensive and insurance does not cover them. So that could be a reason to potentially do more in those cases. Let's see. Another concern with this is actually skin breakdown. Mm-hmm. Okay. Now, behavioral things that we talk to all of our patients about. The first thing is what we call bladder training, and that can vary based on the patient. So, for example, if a patient is saying that they're only going to the bathroom 3 or 4 times a day, we're like, well, maybe we're waiting too long. Maybe we need to go to the bathroom every 3 to 4 hours, regardless of that urge, instead of waiting until that urge is impossible to control. Okay. But then there is kind of the flip side where the bladder is just, again, even if it's just full a little bit, then it just wants to squeeze and go. And we have to train that bladder to hold more like it used to in the past. So again, that can be kind of variable what we do there. Now, there is something, I don't know if you've ever heard of this. It's called latchkey incontinence. It's not like a true medical term per se, but I will have so many patients tell me that the moment they, go into their garage or the moment that the key goes into the door, that they have an accident. And it is a very common phenomenon. Basically, we get conditioned to need to go. And sometimes the brain, again, is involved in this. So what we can do is what we call urge suppression techniques. So if we get a strong urge, or if we know we're about to be in that situation where we do traditionally get an urge, what we can do is what we call quick flicks. So are you familiar with Kegel exercises?
Mm-hmm. Yep.
Okay, so imagine you're doing a Kegel real fast, and it's a squeezing of the pelvic floor muscles. When we do that, go squeeze, 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 there is a reflex to the bladder, and it helps the bladder to relax. And if we distract our minds at the same time, and we may have to sit down and, again, just distract ourselves, then sometimes we can overcome that bladder spasm and walk to the bathroom, or kind of just ignore that urge. So those are little things that we do and teach our patients in the clinic. Let's see, fluid management and avoidance of bladder irritants. So, if patients come in and they're drinking a whole pot of coffee every day, of caffeinated coffee, then sure, that's going to make their symptoms worse. And something as simple as, little changes, maybe changing to half calf or decaf can be helpful. Making sure that they're actually drinking water as well. There's quite a few patients who do not drink any water, maybe just with pills. So, we typically recommend about 1.5 liters to 2 liters of water a day, enough to stay hydrated, keep the kidneys healthy, and 1 to 2 fun beverages a day. So, a cup of coffee, a cup of tea is fine, but not like a 32-ounce Sonic drink.
That's what my patients are always saying. They're like, oh, I don't drink water, but I drink coffee. It's made of water, or tea. It's made of water. Like that's not how it works. We have to be looking for those goals. So I love that you gave us some numbers too, to have as goals for reaching those, that recommendations.
Yeah, so anything with caffeine, artificial sweeteners is actually one that patients don't think of as well, and those can be very irritating to the bladder. So just to be mindful of what we're eating and drinking that's actually making things worse.
Does carbonated beverages, would that, like, let's say you're doing like a carbonated water or something like the Topo Chico or one of those things, do those have any irritation or effect on the bladder? Say, because a lot of patients will say, I hate drinking water. They want something
Hmm.
in it. And yes, they do go for those artificially sweetened ones. But what about something that doesn't have this artificial sweetener, but just the carbonation?
Yeah. Honestly, I don't know the whole data behind that. I think, it's very reasonable to kind of see, hey, what happens? But if someone's getting relatively plain water, I'm oftentimes happy with the carbonation. It might be a little irritating, but everything in moderation, right?
Right, right. Okay, so keep telling us more. What else can we change lifestyle wise to make this something, more doable? More, a lot of people right now are wanting to do like a natural approach, that first line approach. So keep telling us what else we could be doing. This is great.
Yeah, definitely. So, another thing that we often do is send to pelvic floor physical therapy. They are such an
Yes.
important part of our healthcare team. I have one that I texted yesterday because they can help our patients with overactive bladder, with stress incontinence, pelvic pain, constipation, so many things. So, I have plenty of patients who come back and yeah, they're able to control that urge. They're able to control their bladder. So that is always a great resource to have. And thankfully, we do have a handful in town that are fantastic.
And one of the things you mentioned even was like pelvic floor therapy can help with bladder, but also it can help with what Cari always talks about, constipation, using the restroom the right ways. All of that stuff is, yes, all of those things are related. So okay, so let's say we have a patient, and she went through all of these things. She's done her exercises. She went to pelvic floor PT. She comes back. What's our next step?
So, something that happened last year, the AUA or the American Urological Association updated their guidelines. And, previously we did this in a stepwise manner where, we did behavioral and then we offered medications. And if you failed two medications, then we moved on to what we now call minimally invasive therapies, which we'll talk about. It doesn't have to be that way. There are some reasons why, some patients don't want to be on one more medication.
Hmm.
Some patients have different contraindications to medications, but traditionally, the next step is typically medication management. So, with that, there are 8 medications on the market for overactive bladder here in the United States. I have a preference for about 3 of the 8 just because of the side effect profile. So the oldest medication that a lot of people are very familiar with and may have tried in the past is called oxybutynin or ditropan. It just notoriously has the highest rate of side effects. It is the oldest medication. It can cause dry eye, dry mouth, constipation, blurry vision, even cognitive issues. There's more and more data that's come out in the last couple of years about the concern that there may be an increased risk of dementia when we're taking these medications long term. One of our societies is even saying even more than 3 months, and this is a cumulative effect over time. So, this is something that we are told that we now have to talk to all of our patients about if we are either prescribing them or offering them an anticholinergic or antimuscarinic medication like this. Now, there are newer formulations such as fesoterodine and trospium that are least likely to cross into the brain, so less likely to cause the cognitive problems, but still there is that theoretical risk. Thankfully, we do have newer medications on the market, and access has greatly improved in the last 3 years that I've been doing this. So that group of medications is called the beta-3 agonists. There are 2 medications, mirabegron and vibegron. Mirabegron thankfully went generic last year, and access has greatly improved. We are getting so many less phone calls about the cost. What we like about these medications is not only do they work well for the bladder, but there's just less side effects. Patients do really well and tolerate them well. Some people experience headaches with the medications, and we are not supposed to prescribe mirabegron with patients with uncontrolled blood pressure, so that is a consideration. But many of these patients are eligible to try these other medications. And again, cost is not much of a barrier as it used to be. So I'll have some patients who say, hey, they tried sending that medication in before, or I've been on medications before and they cause terrible side effects. Well, thankfully now we have newer options, which is fantastic.
I love it. Yeah, I remember prescribing some of those ones when they first came out and getting none approved. So perhaps if somebody was, think, okay, well, I can't get, some of those newer medicines, they can go back now that, it's gone generic and we have better access these days. And they don't have to stay on the old school medicine like the oxybutynin that, we have lots of people on and they say, they're on it, they have all the negative side effects or the risks. They start reading about those risks about the cognitive changes, the dementia. So they just say, well, I'm just going to stop taking it. I'm just have to live this way for the rest of my life. Maybe they can go back in and realize that these newer medicines, like you said, that are available, more and more access is becoming available. Insurance companies are realizing, hey, we should cover this stuff. It's better than them having complications down the road.
Definitely, definitely. So it's an exciting change. And again, we have lots of patients who do well with these medications. Sometimes if one medication is not enough, at the end of the day, we determine our treatments based on bother. So if we maybe made some improvement, but we're not there, sometimes we add on a second medication, or sometimes we just move on to other therapies.
And what if after all those treatments, a patient still does not have relief? Do they just accept that this is their way of life?
Yeah, so we have 3 different, what we call minimally invasive options. So the least invasive of those 3 is something called peripheral tibial nerve stimulation, also known as percutaneous tibial nerve stimulation. So that's based on acupuncture. And what we do is have patients come in for nurse visits. There's a little acupuncture-like needle that we put in the ankle and we stimulate that nerve. So it's the posterior tibial nerve that we are stimulating for 30 minutes. It is weekly sessions for 12 weeks and then once a month after that. The great thing is a lot of patients are eligible for this. We cannot do it for patients with pacemakers, but other than that, there are not a lot of other contraindications. The thing is a lot of patients don't want to have to come to the office that often. There are implantable versions of this. We're not quite at that time of currently offering them here within our own practice, but it is available in the United States. There are a couple more kind of in development as well. So that may be something kind of coming down the road. It is part of our national guidelines as well to offer these implantable versions of this. So our next option is something called sacral neuromodulation, and this can be used for our patients with overactive bladder. It is also approved for non-obstructive urinary retention and fecal incontinence as well. So we do ask all of our patients if they also have leakage of stool, because if so, then this could be a great option to help with both the leakage of bowel and urine. And if you look at the information from the company, typically they'll say that it actually works better for the bowel, and anecdotally, I actually hear that as well. So when we do that, we do a test in the office. There are 2 companies that do this product. So we use Medtronic's InterStim, but there's also Axonics out there. And what we do is a test in the office. So I work with Dr. Melissa Sanford, and she is a fellowship trained urologist in female pelvic medicine and reconstructive surgery. So I send my patients over to her to do this test that we call a nerve evaluation, or a PNE, and it's a test drive of the device. And we see, hey, would you want to go to surgery for this? When I started with her 3 years ago, she was not offering this in clinic. So it's a great advancement that has kind of come out in the last couple of years. So what she does is she puts wires in the back, and the wire stimulates the nerve, the S3 nerve that is running to the bladder. And patients go home with bandages and a little belt, and they work with the rep and keep a detailed diary. And we see, hey, are things at least 50% better? Would you want to go to surgery for this? If we go to surgery, everything is implanted. The battery site is kind of in the top of the bum, and they have control So they are able to kind of change the settings of the device and kind of go up and down and change programs. So they have a lot of control in that aspect. But the idea is not to have to do this all the time. The idea is to kind of get it to a good setting and kind of forget about it. Maybe change up the settings a couple of times a year. What's great is the newer products are working for 10 to 15 years, and you can have an MRI with it in place, which again, that is something that has changed in the last 3 years. So the technologies are very much improving, which is fantastic. So we have better options for our patients. The last option is, and not that these are necessarily in order, but something else that we offer is something called botulinum toxin. So just like people get Botox in the face, we put Botox in the bladder. So the botulinum toxin helps to relax the muscle. This is a procedure done here in the office where Dr. Sanford will go in with a special camera. It's called a cystoscopy, and she will inject the Botox into the muscle of the bladder. So that takes up to 2 weeks to work. 2 weeks later, we have our patients come back and see, hey, are things working well? And B, we want to see how well are you emptying your bladder, because sometimes we do too good of a job at relaxing the bladder and patients can't empty very well afterwards. So we quote about a 6% risk of that happening. That could be a little bit more if we have neurologic processes or diabetes potentially. But in those cases, sometimes patients have to go home with a catheter or do catheterization a couple of times a day, not forever, for about 4 to 6 weeks until the bladder wakes up a little bit more. Now, most of our patients don't have to catheterize and are pretty happy. I had a patient come back this week and she's at her 6-month mark and things are still working, which is great. So on average, it's lasting about 6 to 9 months. So when it works, it can work really well. And, patients can come off of medications, and when effects wear off, we just have them come back for another round of injections. So that's another option. If you look at literature from the company, just like people who get Botox in the face or for any other reason, there is a risk of, it migrating to other parts of the body causing weakness. I've never seen it happen, but that is a rare complication. With that being said, all 3 of these options, I have patients who do very well and are very controlled. So we have plenty of things to offer for overactive bladder. So I don't want patients to give up.
How fascinating. There's so many treatment options for overactive bladder. Women and men don't have to accept this as normal. Talk with your primary care doctor about treatment options and possible urology evaluation if needed. Okay, Kristen, let's switch gears and jump into our next segment. We want your opinion on this.
So if you haven't seen it already, you should definitely look this up. There is a viral video on TikTok from a physical therapist, Alicia Jeffrey Thomas, who's a PhD, who has 400,000 TikTok followers. And she's talking about why you should not urinate in the shower. And this is actually fascinating.
Dr. Jeffrey Thomas is a pelvic floor therapist who explains that there are 2 reasons to not urinate in the shower. One, when you habitually urinate in the shower, you're essentially conditioning yourself to associate the sound of running water with the need to urinate. It's the same thought process as the famous Pavlov's dog experiment, in which dogs were conditioned to associate various stimuli or inputs with getting food, and so they would salivate at the sound of the inputs alone instead of the food. If you suffer with pelvic floor dysfunction, where controlling your bladder is already an issue, this could lead to bladder leaks triggered by the sound of running water. The second reason she cited was women can't fully relax the pelvic muscles while standing up, even if you do the famous Captain Morgan position with a leg up. This means they have to push past a barrier to urinate while standing up, which could cause problems in the long run. From a pelvic floor perspective, the position for peeing in the shower is not conducive to pelvic floor relaxation.
So we're really fortunate today to have Kristen here to give us her expert opinion on this whole discussion. Kristen, what do you think? Does Dr. Jeffrey Thomas have this right?
Yeah, Dr. Jeffrey Thomas is spot on. So when I first saw these headlines 4 years ago, I was not working in urology as a nurse practitioner. So I was like, I just shrugged it off. My inner hippie thought, hey, you could pee in a shower, you save a little bit of water. But she's absolutely right. We can condition the bladder to be more overactive, and in this case, associating urination with running water. And also, again, the fact that the pelvic floor can't relax withstanding, again, another reason, unfortunately, not to pee in the shower.
I just think it's so interesting because it's like what you talked about earlier, like the latchkey phenomenon where people all of a sudden, they get in their house, in their garage, and all of a sudden they feel like they have to immediately use the restroom or they, have that leakage of urine. Well, it makes sense, right? It's the same thing with the running water sensation. You're just training your body to do something it shouldn't be ready to do, right? Bladder training is so important. We start when we're little and we're toddlers and we teach them how to hold their bladder and when to use it correctly. Well, we kind of can you can teach old dogs new tricks, right? We can still teach
Yes.
your bladder and train it to do something it shouldn't do. And so that's why it's so important to think about these things.
Definitely. And as a mom, I kind of think about, okay, I shouldn't kind of encourage maybe them, peeing right before they leave every single time, because
That makes sense.
I have 70 and 80-year-olds saying, hey, my mom told me I had to pee every time I left the house, and they're still doing this decades later. So just as an FYI, make sure they're peeing, but.
That's a good point.
This is the best. Who knew there was an effect on your health related to urinating in the shower in a way you may not have expected at all?
Thank you again so much for joining us today, Kristen, and all of your insight. Don't forget, if you're a listener claiming CME credit for this episode, please look in our show notes for instructions.
And for our listeners, thanks for tuning in. Please like, subscribe, follow us on socials, and share the episode. Let us know what other topics you're interested in through our Instagram and TikTok, and stay tuned for the next episode.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when new episodes become available. For more information about this episode, and to learn how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. And don't forget, click that follow button to be notified when new episodes become available. The information and content has been made available for informational and educational purposes only, and does not constitute a physician-patient relationship. If you need medical advice or help, contact your personal physician. The views and opinions of the guests do not necessarily represent the views or opinions of Dr. Jessica Gray and Dr. Cari Sorrell. This podcast should not be considered as an alternative for medical advice, diagnosis, or confirmation of an illness or disease. Please seek assistance from your personal health practitioner.